pride in the school's mission to serve the patients and provide health care to the best of our ability here in Louisiana. With these proposed rule changes, my fear as a student, and the fear of many students, is that future generations of PAs will leave the state in order to practice more freely to states such as Arkansas, Mississippi, Texas especially, because those states have more of a progressive set of rules that allow for more of expanding coverage. And with the strain on the healthcare today, we just feel as students that this would be unfair to the patients, not just to us as PAs coming up. And that's what really counts, is the patients. In addition, we as students feel that this would actually be a step backwards as far as PA is concerned in the country, because in a country that's moving forward to meet the healthcare demands and expanding coverage, we just feel that the proposed rule changes would be a step backwards. Most of the other issues as far as students have been addressed, and we are in line with a lot of feelings of these current physicians that have spoken before. And I just wanted to once again thank you for your time and allowing me to speak as a student here today. Thank you.
Thank you, Mr. Jackson. The next speaker is Terry Martin.
Good morning. My name is Terry Martin, and I'm a current, although atypical PA student at LSU in Shreveport. For 20 years, I was a practicing AA, which is the anesthesia equivalent of a PA, trained at Emory University. My wife is a Louisiana native. She's a radiologist at LSU. She's a highly trained trauma radiologist, of which there are few in this state. After 10 years of traveling, because I could not work in this state as an AA, I decided to go back to school. Well, what happens the first month of school? I hear now that I may not be employable in this state as a PA. And one of the point I would like to make to you is not only that the state is investing a lot of money in our education. We're all old enough to know and have heard that our tuition doesn't cover our training.
Good morning. Thank you for allowing us to speak to you this morning. I'd like to begin by saying I'm a obstetrician gynecologist who practices in a rural health community. In fact, when I began to practice in this community, the obstetric and delivery program and labor and delivery services in this hospital community had been closed for 4 years. I grew up in a rural community and wanted to return to a rural community to practice. Prior to medical practice, I did veterinary medical practice for 10 years and opted to return to medicine and return to a local community similar to what I grew up in to provide these services. It is very difficult to maintain a practice in obstetrics and gynecology in this rural environment. The patient population mix, the payer mix, and the difficulties that exist within providing care in these communities is real. It's becoming more and more real as changes in healthcare occur. Specifically in the last year or two, we've had significant changes that are making it even more difficult to maintain practices in these communities. I have always maintained and utilized mid-level providers in my practice. Once we got the practice built to a level where we could sustain it, mid-levels were included, initially with nurse practitioners and currently with physician assistants. I've had the opportunity to have worked with 3 very good and strong nurse practitioners. And I've had the opportunity over the years to work with 2 very strong and capable physician assistants. You know, I hate to say this, but physician assistants significantly outperform the nurse practitioners that I have had the opportunity to work with. And I believe it's because of their basic training and approach to their training. They're trained alongside physicians, they're trained in the medical centers with physicians. I, in fact, had the opportunity, because I returned to medicine later in life, to sit beside physician assistants in the LSU Shreveport system who took the exact same courses in pharmacology and anatomy and other courses that I myself took as a medical student. I later had the opportunity to work alongside these PAs in training in the clinical rotations within the hospital and outline clinics that we as medical students also rotated. So I've had a first-hand look at the training that these people get. The federal FQHC facilities, we've got one in our community, and I actually have a rural health clinic, which was also part of the model to be able to survive in a practice in this type of community. Without it, you can't survive. You have to be a rural health clinic status in obstetrics and gynecology to financially be able to operate an office. These guidelines require 10% review and co-signature of notes and all things done by the mid-level providers. This board has imposed a 100% review and co-signature on everything my PAs touch. We do it, we will continue to do it because that's what this board has imposed upon us. However, if my PA and I were working in an FQHC facility, this board would require 100% co-signature and review. The federal government only requires 10% in any mid-level provider.
Dr. Fullman, you understand that's not part of this rulemaking effort. That's an existing rule, co-signatures, outpatient record, 72 hours. So that's not part of this rulemaking effort. So that's
It's an existing rule, it's another imposition. I recognize that. I'm simply making a point. Okay. I will speak specifically to the delivering of babies because it's on your list. In my rural community with the rural hospital, in the initial stages of having a nurse practitioner in the program, the nurse practitioner was allowed to do deliveries in my absence. If I'm in the operating room and a patient needs to deliver, the nurse practitioner would do the delivery. She had training. These things don't happen often, but they happen. Rather than me break scrub and leave a patient under anesthesia in the operating room to go catch a baby a couple of halls down, the nurse practitioner was allowed to do these deliveries. She had appropriate training. In any other absence situation, so long as I was readily available, the nurse practitioner was allowed to do these deliveries. In later years, when I now work with a PA, the PA was taught and trained and worked directly with me at bedside on appropriate numbers of deliveries. My limiting number that I chose, because we did not have guidelines in our hospital, was no less than 50. If they want 100, we'll do 100, whatever. We started with a plan of 50. Well, this board provided advice, and this speaks to the notice of intent that was brought up earlier. This provided the hospital. They requested a question on what should PAs be allowed to do in obstetrics and gynecology, and can they deliver babies? Well, this board's response simply stated that although they didn't specifically delegate what the PAs could or could not do, that was part of the supervising physician's role according to the statute. It was the opinion of this board, well, also that indirectly you did supervise them or you did control them because you control our licensing, mine and theirs. But beyond that, in addition to that, it was the opinion of this board that because the possibility of an emergent cesarean section or complicated delivery could occur, the physician should be on the unit, physically present on the unit for the PA to attend a delivery. I would propose to this board that it's most unfortunate that you chose that position because you essentially created a medical legal scenario for the credentialing committee at that hospital that they will not allow a PA to ever deliver a baby unless I'm standing on the unit. If I'm standing on the unit, I don't need the PA's help. I can do it myself. The other thing that this has created, and this board overlooked, possibly, I assume you overlooked the fact that a family practice doctor who does not have cesarean section credentialing or training is allowed to deliver babies so long as he's got an obstetrician gynecologist who is readily available and willing to step up in that need. A nurse practitioner with obstetric training is allowed to deliver babies provided an obstetrician is willing to come forward in a time of need for a cesarean section or complicated delivery. We must be readily available. Why